I mean mean, I don't mean nasty. All the mean things that we did to them, they're going to tell you about it. Right? Okay, so. All right, so do you want to, what position do you want your patient in? And they will tell you. They will start blabbing everything. So-and-so did this to me last night. They will tell you everything.
They've been holding all that in.
So be careful because they always can hear. So you never want to say things in the room. Like this is, blah, blah, blah about this patient. They can hear you. And they will tell when they get out of that situation. Plus it's not nice. You have to be nice to your patients. Okay, so patient's lying flat. What's the first thing you want to do before you extubate the patient? Elevate my patient. I don't want them laying down. And can you breathe if you're laying down? No, you need to be sitting up. Sit that bad boy up. Get up. You want to sit him up. High Fowlers. Sit him straight up. You're going to be extubating him. You want that diaphragm to drop down. You want him to be able to take a deep breath and cough. So you want him sitting up, okay? So we sat him up, all right? And we're going to extubate him. So you are going to attach we've suctioned everything out. You're going to attach your syringe, okay? And we're going to tell him, Mr. Jones, I'm going to just take this harness off of you. We're going to pull this tube out and you'll be able to talk. Now, Mr. Jones, your throat's going to be sore for a couple of days, but that's okay. That's normal, all right? And what else do we need at the bedside? I forgot about this one thing. What do you want to put on him after we've extubated him?
Mask.
Just warm air? Okay, so we used to do a aerosol entrainment mask, okay? But we no longer do that unless we suspect that they have, airway edema, or they have airway edema. So we always put them on a nasal cannula, is what we do nowadays. That's been in the last few years. We've changed it. We used to do cool mist just because the throat would be irritated, and we did that on everyone. Now we don't do it on anyone unless they have suspected edema. Okay, so we're going to get a nasal cannula. So your patient was on 40% FiO2 on the ventilator. What FiO2 are you going to put him on? How many liters nasal cannula?
4.
4. 24, 28, 32, 36, 40.
Oh, yeah.
Use the fingers, people. I'm telling you. 24, 28, 32, 36, 40. 5 liters. So I need to put the patient on 5 liters. What else do I need at the bedside? I'm putting him on 5 liters. Bubble humidifier.
Bubble humidifier.
Anything over 4 and above, you need a bubble humidifier. So you have that because you're gonna, and that's already hooked up. You've already got that hooked up. Okay. You've got this right next to your patient because you're gonna have to suction him out as soon as that tube comes out. Good. All right. So, all right, Mr. Jones, we're gonna pull this tube out. I've just taken this harness off here. Okay, whether it's tape or a harness, you want to get this off. Okay, and you're going to gently peel it off because it's sticking to the skin. Gently peel it off so there's nothing sticking. Okay, the NG tube, big point. So you want to make sure the stomach contents, there's no emesis, nothing left in the stomach. So you're going to put it to suction, or you've already turned off your tube feed. Right? So you never pull out that OG tube or NG tube. OG, orogastric, nasogastric. You never pull out your gastric tube unless you've asked the physician. Remember that. If you remember anything that I'm telling you, remember that. Never pull out that NG tube unless you've asked the physician. Okay? You're not the doctor. That's not your call. Okay? We usually pull it out, but you have to ask the physician, is it okay if I take out that NG tube? Sure, go ahead. Okay? Don't even trust the nurse. The nurse could say, yeah, take out the NG tube. Oh, hell no, I'm asking the doctor. All right? Maybe that NG tube's in there because the patient had abdominal surgery. And maybe the NG tube has to stay in there and the surgeon will kill you if you take it out. Okay? So always check that out with the doctor. So you're going to have an OG or an NG tube. Lots of times it's OG with the ET tube. So, and they never should be taped together. Did we teach you guys that? You never tape the OG tube with your ET tube, because if they pull out the NG tube's laying like this, okay? NG tube's laying like that, and they pull out the NG tube, well, it's hooked to your ET tube, so what's happening? They're pulling out your ET tube too, so you never tape them together, and your cuff is inflated. So what's gonna happen in airway if they pull that tube out with that cuff inflated?
It's gonna
It's gonna
wreck
enter the
shit
airway,
up.
right? Right, so even when you're suctioning, I mean, when you have a patient who's hooked to, you always keep this hooked, right? You always keep this hooked because of bacteria, you wanna keep it a closed system. All right, some people leave it like this, and they lay it like this. Okay, and it's just laying like that. What can the patient do if it's laying like this?
Pull on
Their
it.
hands are here. They want that tube out, right, if they're tied down. So I always say, keep it like that. Can they reach that? Keep it away from their hands, all right? You don't want them pulling that tube out, okay? Those are just some extra things that you'll learn clinically, when you're in clinical. Okay, so we have done everything, and patient's sitting upright, and now we need to deflate the cuff. We've already cleaned out oral secretions from the oral pharynx. So now we're gonna tell him, Mr. Jones, I'm going to have you take a deep breath in. When you do, I'm gonna pull out this tube. Why do you pull out the tube when they take a deep breath in?
Opens the glottis.
Because it opens the glottis. What's the smallest portion in the airway on an adult?
The cricothyroid.
That's on the child.
Oh.
Cricoid's the smallest in the child. It's actually the cords. So you don't want to damage the cords, and we're going to talk about that, because I know I really haven't got much in the PowerPoint. By the way, what time is it? 9:23? Okay. All right.
Right on time.
All right, cool. Cool, because I haven't even started. That's another story. All right. So, okay, so we need them to, on inspiration, you're gonna pull that tube out and you're gonna tell them everything, okay? So, Mr. Jones, I'm gonna have you take a deep breath in. You're gonna deflate this cuff. You've already removed this, okay? Okay, deep breath. Oh, and before you do that, you've hooked this up to this, right? So this is ready to go. Okay, Mr. Jones, take a deep breath in, deep breath, and out, 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 out it comes. Good job, Mr. Jones. Cough for me. Cough. He's sitting upright. I want him in high fellers, okay, for the diaphragm. Cough for me. Good job. Good job. Excellent. Good job. What am I doing next?
Nasal cannula.
It's nasal cannula. I throw the nasal cannula on this patient. Nasal cannula's on, 5 liters. It's already on. I've already turned it on. I just put it on. 5 liters. Take some breaths in and out through your nose, Mr. Jones, because that's where your oxygen is coming from. Okay, in and out through your nose. Good. Good. Sit up for me. Nice deep breath. Try to cough. Now what am I doing next?
Checking his heart rate. Checking
Okay,
the
that's all on the
stats.
screen. So you're watching all those vital signs. Everything looks good. So what am I doing next? I'm going to auscultate. Where am I auscultating first?
The trachea.
Trachea. Okay. So I'm just going to listen over your neck just to make sure I hear good air movement. Okay. No stridor. Good. But you're not going to tell them any medical terms. Okay. Then you're going to auscultate, right? Right and left. Make sure you have good bilateral breath sounds. And then what do you think you're going to do? What would you like them to work on? They just got extubated.
Incentive spirometry.
Instead of spirometry, so you're going to have one at the bedside. That was something we didn't talk about. You're going to have one at the bedside ready to go. All right, you're breathing on your own now. We need to work on taking some deep breaths. So we're going to use an incentive spirometer. So that's what
So you do that right after.
we do that right after. Yep. Yep. And we will work on them every hour or so. We're going to work on that to make sure they take a deep breath. Okay.